We proudly present to you the very first episode of Mulligan Clinical and Scientific Lectures. This lecture will be about proposed mechanisms by which mobilizations with movement work. It will be presented by Professor Wayne Hing. We would like to thank him for his valuable contribution to this project. Professor Wayne Hing enjoyed a distinguished career in the field of musculoskeletal physiotherapy. He has a PhD in anatomy, as well as a Master of Science in Physiology, both from the University of Auckland, along with postgraduate qualifications in orthopedic manipulative therapy and acupuncture. Professor Wayne Hing has been an accredited Mulligan concept teacher from 1997 till 2019. He is now an honorary member of the Mulligan Concept Teachers Association. He held previous academic positions at both Auckland University of Technology and Unitec. Since May 2012, he has been a professor in physiotherapy and head of the physiotherapy program at Bond University. Professor Wayne Hing has also published over 120 peer-reviewed journal articles and written 2 books related to the Mulligan concept, as well as several book chapters. To date, he has supervised over 70 higher degree research students to completion. In terms of research, Professor Wayne Hing has received funding for over 60 projects. He is regularly invited to deliver conference presentations at national and international symposiums. We hope you enjoy this lecture.
Hi, my name is Wayne Hing, and I'm a professor at Bond University in Australia. Today, I'll be presenting a talk entitled Proposed Mechanisms by which Mobilisation with Movement Works. This talk is based on 3 textbooks that I was involved with. The first, as you can see, produced in 2011, the second in 2015, and the third, second edition of the Mulligan Concept of Manual Therapy Textbook of Techniques, which was reproduced in 2020 by myself and Toby Hall. The first book, Mobilisation with Movement, The Art and the Science, had 4 authors. We can see them at the top: Bill Vicensino, myself, Toby Hall, and Darren Rivette. We also had contribution from 3 other authors around the mechanisms chapters: Leanne Bissett, Michelle Sterling, and Paul Hodges. The chapters in this book included a chapter around the efficacy of MWMs, a systematic review, positional fault hypothesis chapter, a new proposed model of the mechanisms of action of MWMs, and then a chapter on pain and sensory system impairments and motor and sensory motor deficits related to MWMs. Biomechanical and neurophysiological mechanisms are both implicated in the action and effect of an MWM. It is apparent that much of the original evidence on the effects of manipulation of manual therapy have predominantly focused on the hypothesis of underlying mechanisms of actions that were biomechanical in nature, with an emphasis on effects described as stretching, tearing, straightening, and reducing. A variety of proposed lesions have been suggested to exist, with emphasis on structures such as bone, joint, muscles, nerves, and blood vessels. In more recent times, the focus in research has highlighted the involvement of the nervous system and pain-related sciences. The often substantial improvements seen from applying an MWM has implied that a transient change in bone position is a critical element of input into the central nervous system. In regard to the central nervous system involvement, MWMs have been shown to produce a non-opioid mechanical hypoalgesia, which is regarded as evidence of central nervous system involvement. That is, the MWM, through its mechanical perturbations at the treated joint, is an effective stimulus to instantaneously trigger processes within the central nervous system, which are responsible for bringing about the clinical improvements seen. A large component of the central nervous system involvement appears to be the endogenous descending pain inhibitory system. With respect to the psychological system involvement, all interventions applied to patients with musculoskeletal pain influence a range of non-physical factors, such as the patient and practitioner's pre-existing beliefs regarding injury, tissue damage, and pain. From a mechanism of action perspective, it is apparent that the patient-practitioner interaction prior to the MWM application is influential. Further, the test application retest feature of an MWM, which provides immediate feedback for both patient and practitioner, is instrumental. However, how these factors influence the underlying mechanisms of MWMs still requires further research and clarification. A patient's willingness to please, or placebo, or not, is often linked to the psychological system. There appears to still be a number of things to consider with regard to placebo with respect to the effects and mechanisms of an MWM. Importantly, it is critical to remember that unlike the placebo pill, it is very difficult to devise a credible placebo for a manual therapy treatment. In chapter 6 of this book, entitled Pain and Sensory System Impairments, let's have a look at this. In broad terms, the sensory characteristics found to be present in varying degrees in musculoskeletal pain conditions include mechanical hyperalgesia, thermal hyperalgesia, hypoesthesia, heightened motor responses following sensory stimulation, and sympathetic nervous system changes. A number of pain processes may be inferred through these various presentations. Past investigation of manual therapy, and more recently MWM treatment, has demonstrated a likely neurophysiological effect of these approaches, manifested by their influence on pain, sensory characteristics, and the sympathetic nervous system. Chapter 7 looked at the motor and sensory motor deficits and likely impacts of MWMs. A number of features were presented in this chapter. Movement is affected when pain is present, and the underlying mechanisms appear to be time-dependent. That is, different mechanisms are involved early after injury or pain onset versus a chronic presence of pain. Secondly, the classic vicious cycle and pain adaptation theories do not satisfactorily explain the likely mechanisms of altered movement in those who have pain. Evidence indicates that there are multiple levels, the nervous system adapts a protective strategy in acute pain, which involves redistribution of activity within and between muscles. While in chronic musculoskeletal pain, there is altered activity within and between muscles, which leads to an impaired control of movement and changes in load distribution across joints. MWMs, with its fine-tuning of specific glide direction, may well be an appropriate modulator of this imbalanced activity across muscles and joints. And finally, there is preliminary evidence that MWMs may directly influence the sensory motor nervous system in bringing about improved movement. The book that we wrote and produced in 2015, The Mulligan Concept of Manual Therapy, concentrated more on the techniques presentation. The general science underlying the mechanisms of MWMs referred back to this first book that we wrote. However, when we reproduced the second edition, the Mulligan Concept of Manual Therapy Textbook of Techniques, we had the contribution of Dr. Daniel Harvey, who did his research with Lorimer Moseley, as you can see. Within the introduction, we had a section around the proposed mechanisms by which MWMs work. Over recent years, our understanding of the mechanisms of pain has greatly expanded. Broadly speaking, pain mechanisms can be divided into contributors from three system domains. These are peripheral, input, central, processing, and response output system domains. The first domain, input, peripheral mechanisms. We consider factors that might contribute to the increased nociceptive signaling to the central nervous system. These factors might be immune, inflammatory, mechanical, neurogenic, or a combination of all. If we look at the second domain, central and processing mechanisms are those that increase synaptic efficacy in pathways relevant to pain and nociceptive processing, or broadly termed, central sensitization. Central sensitization is not one process, but rather an umbrella term for a range of processes, not all of which are well understood. Typically, central sensitization refers to an increase in the gain of nociceptor to nociceptor interfaces. Other centrally acting processes to also consider include bioplastic adaptations, often referred to as functional reorganization, cognitive and affective variables operating at the level of complex expectations and information processing, and thirdly, associative learning mechanisms that are posited to link pain responses to non-nociceptive stimuli. The third domain, or response systems output. We consider protective nervous system mediated responses that might initially be adaptive, but if persistent, may contribute to a cycle of pain or movement dysfunction. These potentially maladaptive responses include efferent motor, sympathetic, neuroendocrine, and neuroimmune responses. MWMs, to the extent that they are effective, are linked to the interaction with underlying mechanisms of pain and movement dysfunction. After all, they cannot influence pain and movement if they do not influence the biological processes underlying it. So what are the possible interactions between MWMs and the mechanisms underlying pain and movement dysfunction? In this book, we looked at these under the three headings: peripheral mechanisms in MWMs, central mechanisms in MWMs, and MWMs and the output or response mechanisms. So let's look at the peripheral mechanisms in MWMs. Historically, the assumption has been that manual therapy affects pain by altering alignment, mechanical function, tone or tissue extensibility, and that any change in pain results from the resulting change in mechanical forces and tissue physiology. A large number of clinical observations led Brian Mulligan to favour a positional fault hypothesis. He noticed that many of his patients who presented with peripheral joint problems demonstrated remarkable improvements in pain and range of motion following applications of his novel manual therapy technique of an MWM, and it could be explained consistently by his positional fault hypothesis. While some evidence has supported suspicions of static bony alignment in some patient groups, there lacks strong evidence that MWMs actually correct alignment. Several alternative hypotheses regarding the mechanisms responsible for the effects of MWMs have been put forward. One of these is the altered mechanoreceptive input during MWMs. As with any valid theory, any explanation for the effect of MWMs must account for the observed phenomena. These observations seen with an MWM include normally painful and or restricted motion can be dramatically improved during application of an external force during that motion. Number two, A certain degree of force is required to achieve benefit. Number 3, improvement is generally dependent on the direction of the applied force. And number 4, the change in movement and pain often persists for at least a short period beyond the application of that MWM. The immediate effects on pain and the direction and force specificity of the MWM, as outlined in these 4 points above, can be explained by understanding mechanoreceptor function. Mechanoreceptors are present throughout the somatosensory system with an afferent, nociceptive, tactile, and proprioceptive neurons. MWMs are only applied where a symptom of pain and or stiffness coincides with movement, suggesting that mechanoreceptive input is linked to the presenting symptoms. Animal studies suggest that articular and periarticular mechanoreceptors elicit distinct activation under different loads and respond to specific directions of strain. The application of an MWM technique may alter the force and or direction of force exerted to mechanoreceptors in the applied region, which will subsequently alter the suite of mechanoreceptor input to the central nervous system. Mechanoreceptor input may be nociceptive, pain facilitating, or tactile proprioceptive, which is generally pain inhibiting. Thus, an MWM might reduce symptoms either by reducing nociceptive signaling or increasing non-nociceptive signaling. Of further note, provided sufficient force is applied to alter mechanoreceptive input, a change in symptoms will likely result, regardless of whether a positional fault is present or corrected. So let's look at the second domain, MWMs and central mechanisms. The question is, does pain alleviation by an MWM prove peripheral dysfunction? Theoretical and established mechanisms exist whereby non-nociceptive mechanical input can come to trigger pain. The most common example of this is allodynia, whereby central sensitization processes allow non-noxious stimulation to trigger pain. While pathways responsible for non-noxious mechanical information are anatomically distinct to those responsible for noxious information, potential facilitatory connections exist between them that become activated as part of the sensitization process, thus allowing tactile and proprioceptor inputs alone to cause pain independent of tissue state or nociception. Distinguishing movement pain associations. Since musculoskeletal pain is frequently associated with movement, kinesthetic feedback, such as that from mechanoreceptors, might become conditioned stimuli capable of contributing to pain. This provides an intriguing possible explanation for the observations of Mulligan and for the apparent effectiveness of MWMs. That is, if a specific package of normally non-painful mechanosensory input, such as that when a bending movement, comes to contribute to pain, because of its prior association with pain, then specific alterations of that mechanoreceptor input using MWM techniques might help to explain the immediate pain alleviation. Further, repeating the movement in a relatively pain-free manner afforded by the application of that MWM may assist to break the association between movement and its cause of bending with pain. Indeed, it has previously been suggested that MWMs might be repeated in order to facilitate relearning of previous pain-free motor memories, and that this might occur through the same physiological and behavioral mechanisms that distinguish aversive memories. The suggestion is that an MWM targets a patient's specific physical tasks that is associated with pain, and by enabling the task to be performed in a painless manner, it is seen as a learning strategy. In classical conditioning theory, this strategy is known as extinction learning and is thought to diminish the learned response by weakening the association, in this case between the movement and pain, and reinstating implicit pain-free movement memory traces. Centrally mediated inhibitory mechanisms. Manual therapy in general is known to induce activation of temporally acting analgesic mechanisms. Generally speaking, the effects of an MWM appear to include similar analgesic effects of other manual therapy interventions, including non-opioid mediated mechanical hypoalgesia. That is, an example is reduced mechanical sensitivity that is non-Nexolone reversible and does not show tolerance to repeated applications. Let's now look at the third domain, MWMs and output or response mechanisms. Let's look at pain in the motor system. Changes in patterns of muscle activation are a common response to pain and injury, and they're thought to serve as a protective function in that near term. In a case where an MWM's application immediately reduces pain with movement, it can be deduced that a particular pattern or quantity of mechanoreceptor signaling is contributing to pain, and that altering that pattern through external force reduces it. Since an external force can alter symptoms by altering the mechanoreceptor activation, it is within reason that altering internal forces by altering motor activation might also be capable of reducing pain. Altering patterns of muscle activation through motor control training has been one approach to this aim, although with mixed reports of success. It is possible that rehearsal of movements under the pain-reducing influence associated with an MWM may provide a different approach to altering muscle activation patterns. There are several reasons as to why rehearsal in this way might alter muscle activation. For instance, patients who are more fearful of movement tend to have greater alterations in muscle activation. Rehearsing movement in a less painful manner might result in more confidence performing the movement and a subsequent relative normalization of muscle activation. Mechanoreceptors in the motor system. For each motor command, the nervous system generates a copy of the expected sensory feedback, known as an efferent copy of the expected proprioceptive map. This provides a pathway whereby changes in mechanosensory feedback might elicit changes in motor activation. That is, the application of an MWM might create a discrepancy between expected and actual sensory feedback, eliciting a change in motor activation intended to correct that discrepancy. Indeed, at least short-term changes in motor function have been shown following MWMs in some body regions. For example, an MWM at the elbow in people with lateral epicondylalgia results in an increase in grip strength when applied to the affected side. Indeed, other inhibitory and facilitatory links exist between mechanoreceptors and the motor system, such as mechanisms responsible for the well-known contract-relax phenomenon. Finally, the possibility of sustained benefit. Generally speaking, the duration of peripheral, central, and motor changes in response to MWMs needs more investigation. A number of characteristics of MWMs distinguish it from other manual therapies and may give it unique capacity to induce sustained benefits in some patients. Of particular note is that mobilizations with movements integrate manual therapy with active movements, and moreover, It can often render these active movements pain-free, or at least for the duration of the application. In this chapter, we have discussed mechanisms such as reassurance, extinction learning and exposure therapy, and also motor learning that might result from experiencing a normally painful movement in a pain-free or at least pain-reduced manner. If there is sufficient rehearsal and functional context, then it is possible that more lasting effects might result, particularly when augmented by other biopsychosocial considerations. Further interactions between the direct and indirect effects of MWMs might contribute to a more sustained effect in well-selected clients. For example, if the reduced pain and reduced fear of movement alters motor system performance, then this may in turn change kinematic function, resulting in altered afferent sensory signaling via altered mechanoreceptor activation. In summary, with respect to some of the indirect and direct effects of MWMs, the arrows in this diagram highlight potential downstream and reciprocal interactions among mechanisms, providing potential pathways for improvement beyond the immediate mobilization with movement application. I hope you enjoyed this talk. Thank you.